Well, good afternoon, everyone. Welcome to this multimodality imaging session. This will be a continuation of the session from last week where the assessment of prosthetic aortic valve was presented, and the session was split of the assessment on echo and then the assessment using CT. Today is the same thing, but we're shifting to the mitral valve. I'm going to be presenting the echo assessment of prosthetic mitral valve dysfunction, regurgitation, and stenosis, and Dr. Chang will be presenting the CT assessment. So as an introduction, there's a lot of prosthetic valves, and they're increasing, every year. There's a new one. And the more there's complexity in design, anatomy, and all these features, the more it becomes complex to kind of follow and then for the guidelines to catch up on how to assess their dysfunction, right? They have different gradients, different jet characteristics, all those things. So really, it can be complex, and it's almost never a single modality to assess prosthetic valve dysfunction. It typically requires multimodality approach. It's, namely echo, TTE, TEE, CT, and MRI. So think of CT is more for mechanism of the dysfunction. MRI is more for the quantification, and echo between TTE and TEE is for both, right? So TTE more of a screening, quantification, TEE more of a mechanism and also quantification. So we're gonna start with the prosthetic mitral valve regurgitation assessment as a kind of basic kind of knowledge for everybody is that most of prosthetic mitral valves have some form of regurgitation, right? We typically call them physiologic jets, normal or washing jets. I don't know if these are by design or because they're imperfect, but typically the regurgitation occurs at the hinge points. So if you have a bileaflet mechanical valve, you will see those like two small jets coming out of the hinge points. This is considered normal, right? The other thing that you need to know is that prosthetic mitral valves specifically are very tricky on TTE, especially the mechanical ones or whenever you have a lot of metal, because of the positioning of the views that we usually use, the parasternal long and the apical. You will have the ultrasound bouncing off the metal, so you won't see what's behind it. And a lot of times you have the blood cavity, right? Whether it's the left atrium or the left ventricle, which is dark, and it's difficult for you to appreciate that there's a shadow over there that's blocking the visualization behind the valve and whether there's a regurgitation. So because of those features, we typically rely on continuous wave Doppler, right? The inflow. A lot of times we rely on the features of that inflow, which I'm gonna talk about, in order to figure out or try to guess or suspect whether there is significant mitral regurgitation or no. So some of those features are obviously, when you do the mitral inflow, the E wave, right? The velocity of that E wave. Typically, if it's more than 1.9 meters per second, you should start thinking that there is something going on there. And some of those overlap with stenosis as well, but we're gonna talk about how to differentiate those two. The mean gradient elevation, also that increases with mitral regurgitation and stenosis. Whenever you have significant MR, the flow back through the valve will be increased because of that, because in addition to the systemic flow, and you will have an elevated gradient. The ratio of the TVI of the mitral over the LVOT, I'm gonna talk briefly about that as well. Typically, whenever is more than 2.2, you have to suspect regurgitation and stenosis. And stenosis, this ratio increases because the TVI of the mitral valve increases, but the LVOT TVI is still the same, right? But in regurgitation, the inflow, the ratio increases mainly because the VTI of the LVOT drops, right? But also you have a VTI of the mitral increases slightly because of the regurgitation. So they both end up having a high ratio. Very important, if you see a mechanical valve with good ventricular function, sometimes hyperdynamic, but the LVOT TVI is low, right? If you have a decent sized left ventricle with a hyperdynamic function and you do LVOT TVI and you see 16, 17, there's something wrong. You have to start thinking there's a missing output there, right? And obviously, if you have secondary effects of possible regurgitation in the form of pulmonary hypertension, right? So if the TR velocity is elevated, you see, there's pulmonary hypertension, there's no other reason, you have to start thinking there's some dysfunction in the valve that you are missing. So again, because of this attenuation that you see here, you have to rely on the Doppler. And I want you to do some pattern recognition here. because, and I'm gonna show later how the mitral stenosis Doppler looks like. But in general, when it comes to mitral regurgitation Doppler, you have a high E velocity, and this drop is usually, like the pressure half-time is usually short, right? In mitral stenosis, this is not as short because in mitral stenosis, you have maintained LA to LV gradient throughout diastole, because obviously these are velocity maps, right, the Doppler, so it's a gradient map. So if you have mitral stenosis, the gradient is maintained, so that line, the red line here, the pressure half-time or deceleration time, is usually more horizontal, if you will, right? So this has been studied actually by, in this institution, Dr. Zogby, Dr. Quinones, back in 1999, looking at those features, on TEE, correlating like how much they correlate in terms of their accuracy with prosthetic mitral regurgitation. If you have E velocity more than 1.9, very accurate. You have to, again, suspect it. Mean gradient more than 5. TVI ratio more than 2.5, very specific. If you have a TVI ratio more than 2.5 and a pressure half-time less than 130, like this case, in this case, for example, this is almost 100% specific for mitral regurgitation, right? Because this combination of high TVI ratio and short pressure half-time usually happens in mitral regurgitation. In mitral stenosis, the pressure half-time is high. Again, I'm gonna show the example of that and how to differentiate those two. Briefly, I wanna talk about that DVI ratio because we talk about it a lot, and I put here the prosthetic aortic valve as well because we mainly talk about it there, but also it applies everywhere. The DVI ratio that we talk about, obviously in aortic stenosis or prosthetic aortic valve, we see like, if it's less than 0.25 or less than 0.5 in TAVR and all these numbers that you use. In the mitral side, we talk about 2.5 or 2.2, but what is it? What are those numbers? Obviously, it's unitless, right? Because you're dividing DVI or VTI over VTI. But it's simply a rearrangement of the continuity equation, right? So, and I put here, for example, for the aortic valve, the DVI ratio that we calculate every day and we report 0.7, 0.6, 0.5, whatever, is simply the aortic valve area over the LVOT area, right? Meaning if you report a DVI of 0.25, you're indirectly saying that the aortic valve area is a quarter of the LVOT area. That's what it is. However, big asterisk here, that statement is correct only if you're measuring the LVOT area, meaning the LVOT diameter, and the LVOT TVI in the same location. This statement that I just said, that 0.25 equals quarter of the area, of the LVOT area, only is true if you did measure the LVOT TVI and the LVOT area at the same location. And that's difficult to achieve because the sonographer provides you with an LVOT TVI. They place the pulse wave cursor in the LVOT. Sometimes they provide only one. And then you go and measure the LVOT dimension, and it might not be at the same location, right? So that's very important to know and to realize because there's a lot of hype about the DVI ratio without really looking into its details. Same going back to the mitral valve, same thing, right? So a DVI ratio of so here it's reversed, but it's the same thing, right? DVI ratio of the mitral inflow over the LVOT is essentially equal to LVOT area over mitral valve area. So when we say the DVI ratio is more than 2.5, you are saying that the mitral valve area is 2.5 smaller than the LVOT area. That's what it is. But again, it relies on the fact or on the premise that you did the LVOT TVI and the LVOT diameter in the exact same spot, right? And obviously, this is an effective area, right? Because in the presence of mitral regurgitation, you will still have the ratio that is high, but not necessarily the area is low, right? So that's why there's an effective component. I just put this slide there so we can clarify this concept once and for all. Obviously, beyond the jet, let's say beyond the spectral Doppler, we did the spectral Doppler, we have a suspicion. We have to also look at other features, if we can, whenever they are present. So I'm gonna focus here on the specific criteria for severe prosthetic MR. Obviously, if you see a valve that is, abnormal, what does abnormal mean? There's rocking motion, dehiscence, even if you see like some calcifications, right? So typically, let's say if you have a bioprosthetic valve, whether it's on the aortic or mitral side, if the leaflets are normal, typically you don't see them. They're almost invisible to most echoes. Once you start seeing the leaflets, and when they're calcified, there's something wrong, right? If there's calcified leaflets, a stuck leaflet. So this is a feature that you have to start to think about whenever you're looking at the assessment of regurgitation or stenosis. If you have, the rest mostly applies, to native MR as well. So if you have a vena contracta width that is wide, if you have more than one jet, again, this is something that is more typical in the prosthetic world. Vena contracta area, we're gonna talk briefly about it because this usually needs 3D. If you have a large pisa, same as native. If you have a jet that occupies a big portion of the left atrium, and obviously hemodynamically, if you have pulmonary vein reversal, that's very important, right? So who can tell me if they see anything unusual about this TEE with the bioprosthetic valve? Okay, the animation played by itself. But in this case here, you can see that visually there's a gap, but that's never enough, right? Whether it's on echo or in TEE, you have to supply it with a Doppler in order to really see that there is truly a jet, right? On top of it, if you notice carefully, there's also flow during diastole, right? And that's usually a feature of a large gap, large regurgitant orifice. So sometimes it's that clear. In other cases, it's not as clear. So this is, for example, a annuloplasty ring, and on top of it, there's a clip, and you have such jet. There's something abnormal, but you tell me how can you, it's probably more than mild, but like, is it severe? Is moderate? They're not as straightforward. If you go to the clip world or the M-TEER, it can become even more complicated. You put one clip, two clips in different orientations and places, and you might end up with many jets. And then you tell me how can you assess this? So it can become really complicated. So you have to be really careful, and you need to have a good set of rules of how to assess those lesions. Speaking of M-TEER, it has a unique feature in terms of assessment that it's the only intervention where you have to learn not to only assess regurgitation in general, but to also assess it immediately after the procedure. So most of the time we talk about assessment of regurgitation, in an ultrasound that you see, but also in this particular case, you have to assess it on the spot, right? And this is a kind of a little bit of a different animal. So you have to go, this is separate in a way, but you have to mention it, and we have to mention it and learn about it, right? So briefly, we're gonna talk about what features represent significant reduction in mitral regurgitation, right? So some are, I thought I stopped this auto transition. So some are related to the color Doppler, right? So if you see a jet that's almost gone, right, or you have a central jet doesn't occupy much of the left atrium, we all know when you see this, the MR is almost completely gone. You're confident with it, right? Another feature is I mentioned earlier, is the vena contracta area, and this is particularly useful in cases of mitral regurgitation post-M-TEER, because you usually create multiple jets. However, the issue with it is it needs expertise, it needs time. That's not something you can do on the spot in the lab, but unless you have good images and good expertise. But the idea is you have 3 jets, you trace the vena contracta area of each, and then you add them together. Typically, if you have less than 0.2 centimeters squared, also you're more confident that this is on the mild. From a hemodynamic standpoint, the pulmonary veins obviously are very important, as you all know. If you already started with a blunting or reversal, and then now you have the S-wave resurrection, essentially what you did is the LA pressure, you dropped it, so now the flow from the pulmonary veins into the left atrium is permissible, and you have the S-wave shows up, so you know that now the MR is significantly reduced. The forward flow in the form of the LVOT TVI is also very important. And the paradoxical decrease of the LVEF is also important. It's not usually decrease as much as it is uncovering of the EF. You reduce the afterload significantly, or you increase the afterload, right? Because you abolish the MR. So now the EF kind of shows its true reality in a way. And then you know that the MR is decreased. And then last but not least is the left atrial appendage. Sometimes you see suddenly, spontaneous contrast in the appendage, typically in low flow situations, right? But that tells you that, the MR is no more washing that flow. There's no more turbulence in the left atrium. That's why you could see it. So on top of that, obviously, you have the advantage in the lab of the hemodynamic catheter parameters that you can use on top of that. A study from here about the vena contracta area again. If you have the time to do it, which I encourage the advanced fellows to do because we have the software and the availability of all the tools to do it. What we found in this study is a vena contracta area of 0.27 centimeters squared identified fairly accurately MR that is more than moderate. And last, which again I'm a big fan, is the volumetric method, right? This doesn't care whether you have multiple jets, eccentric jets, whatever it is. It rests on also on the idea that you need good images, right? Ideally, if they do good images with contrast, no foreshortening of the ventricle, you can get a good, decent, LV, total LV stroke volume, and a good LV OTTVI. You just subtract those two, you get the regurgitation and regurgitant fraction. Even if you have aortic regurgitation, that still works. So this is a great method, but again, you need good images to be able to apply it. Again, last on this, on the mitral regurgitation, is summary of the when you suspect significant MR, if the ventricle is dilated, as we talked about, if the valve is abnormal, meaning rocking, calcified, stuck leaflets, large jets, if they occupy more than 50% of the left atrium, this is very specific for significant mitral regurgitation. Large pisa, a dense triangular jet is very important if you see it. Obviously, systolic flow reversal, and then the quantification, 60 mLs, 50%. Be careful with that 60 ml, 50%, because it doesn't always apply, especially if you have low flow conditions, right? So in low flow, rely more on the fraction, whereas in high flow, primary MR, rely more on the volume. Next is mitral stenosis. There's not much in this world. It's mostly gonna be Doppler assessment, but I'm gonna show you most importantly, the message here is to how to differentiate on the Doppler prosthetic MS from prosthetic MR. So again, the parameters that you need to look at is the maximal E velocity, right? The mean gradient, heart rate is very important, and that always comes up in the lab as to how to report it, right? Whether it's native or prosthetic. If you have a gradient that is high at 100 beats per minute, or if it's high at 60 beats per minute. To me personally, I favor and I put more weight on the gradient because I think this is what the patient is feeling right now, and I give a equivalence as to diastolic function. You can have a patient who is a grade 1 diastolic function that can go to grade 2 or grade 3 in the right conditions. When we read the echo, we report it as grade 2 or grade 3, and then if they're diuresed, they come back and it's grade 1, and this is how they're feeling at that. So it's, MS is in a way similar, so you can get an MS to be moderate or severe in the right conditions, or back to mild or normal in terms of gradient in the right conditions. So I put more weight on the gradient personally, but you have to always try to get the area out as well. The pressure half time is very important, as we talked before. In MS, you tend to have a longer pressure half time. Why? Because throughout diastole, the LA-LV gradient is elevated. It's not like MR where you have the gush in early diastole and then there's no obstruction to maintain the gradient, right? Whereas in MS, there's always gradient. And then obviously the effective orifice area from the continuity equation. So in this case, for example, just looking at it, this is a Doppler from TEE. You can see that the E velocity is elevated. The pressure half time is 300 milliseconds. Again, more than 200 is significant. You have a VTI ratio of 5.7. It's very high, right? So more than 2.5 is considered elevated. And then you look at the, obviously visually, this is an abnormal valve, right? You see the thickening, the limited opening. So this is a slam dunk case, right? Again, pattern recognition. This is how normal is, right? Focusing on the pressure half time. This is how significant mitral stenosis is, right? So I'm highlighting here what suggests really significant. Peak velocity more than 2.5, and a ratio obviously more than 2.5, and the pressure half time more than 200, right? Continuity equation. It applies the same way we get the aortic valve area from the LVOT and aortic valve, we can do the mitral area from the mitral and LVOT, right? Assuming the same blood is flowing, the same volume is flowing in those both locations, right? So the mitral valve EOA is essentially the LVOT stroke volume over the VTI of the mitral valve, correct? However, this cannot be used if you have significant aortic regurgitation or mitral regurgitation. If you have significant aortic regurgitation, the LVOT stroke volume, the numerator will increase. You will get an artificially elevated EOA. If you have significant mitral regurgitation, the mitral valve TVI will increase. You will have an artificially reduced EOA, okay? It works best, obviously, in regular rhythm. If you have somebody who has atrial fibrillation, since you're measuring two flow locations, if you want to measure them and use them in the same formula, they have to be within the same previous RR, right? So that you get the same stroke volume, right? If you measure one with a short RR, you will have a small stroke volume, and the other with a longer preceding RR, you're going to have a higher stroke volume, and then you're going to have different numbers just based on that. Finally, again, I put those together. Pattern recognition is key. I mentioned this probably the 5th time because I think it's very important. This is on the left, you see how significant MR looks like, whereas on the right is significant MS. The pressure half-time is probably the most important in addition to the gradient. Thank you. This concludes the echo part of this talk. As I said earlier, the yeah, please.
Yeah, let me move while the presentation.
While we load any questions?
No question.
So sometimes there are, I guess, patients who have severe MS and severe MR.
Yeah.
So when that happens, I guess we rely more on the color for the MR and look at qualitatively what's going on.
Yeah, that's a good question because whenever you have valve dysfunction, obviously the valve is prone to have both MR and MS. Typically, one is more dominant than the other, right? You might have like severe MR and some MS or vice versa, right? I think the main point here is that on echo, having a suspicion high enough to say the valve is dysfunctional, right? That's the point. So obviously those Doppler signals will be somewhere in between, right? You will still have high gradient. The pressure half-time, if there's significant MS, will probably still, be elevated. But if you don't see the jet, the assumption is like based on your question, if there's like a combo, at least you can tell that there is a high probability of valve dysfunction with MS plus or minus MR or whatever, and that would lead, to the next modality. Because as I said at the beginning, this is almost never a single modality assessment for those cases. You're gonna need a CT to discover the mechanism.
Right.
You might need an MRI if you want to really know, for example, more accurately how much is the regurgitation, or TE, obviously. Right? So, but yeah, they can happen in conjunction very frequently. More questions? Fill the gap. By the way, MRI, you can do MRI for prosthetic valves for those of you who are not aware. It has been studied up to 4.7 Teslas, prosthetic valves, and they still hold, right? So the forces within the sutures, within the valves, are much stronger than any magnetic field that you apply in the clinical realm. So if you do have a prosthetic mitral or aortic, especially obviously mechanical, and you're looking for regurgitation, because stenosis is not something you can usually assess on MRI. You're assessing regurgitation, think of mitral regurgitation. We will have artifact around the valve, but that doesn't mean you can't calculate the regurgitation because you're just tracing the ventricle and the flow, and then you can get those numbers.
Is it easy to differentiate PVL from Transcatheter MR by MRI, or do you just quantify the
So the question is if we can on MRI identify PVL from transvalvular. I think if the jet is, so typically those when they get to MRI, they probably have significant regurgitation. So if the jet is large enough or the AR is significant enough, yes, you can. Typically, we can see, like, because we do those longitudinal flow assessments, and you can see typically the jet like on the side or in the center. So yes, but if it's like mild or trace, sometimes you can.
Thank you, Carlos. Thank you for your patience. Again, he did the most difficult part. The part requires some thinking. I'm going to show you some images because after the meal, we don't want anybody to fall asleep. All right, so this is most of the valve that we're going to see, the left-hand side, bioprosthetic and mechanical valve. With obviously the transcatheter valve is being fully investigated. Some of them has been approved, like the valve-in-valve, Sapiens. Sometimes we see rings, sometimes we see clips. But mostly the talk will be focused on traditional surgical valve. And this is just a pictorial of all the TMVR has been developed. The one that we're going to see more, you guys are going to see more here, will be the Intrepid valve because we are one of the big sites. And my understanding, the Evoke will be getting started. And obviously, Sapien M3 TMVR is essentially the same as similar to surgical, similar to the aortic valve. So why we do CT? Number one, because there's less artifact compared to echo. And the most important part, I think, compared to 3D TEE for mitral valve assessment, different from aortic valve that we talked about last week. TEE really is the mainstay, and I think 80–90% of the time you're gonna get the answer through TEE. Question is any scenario which you can skip the TEE? We all agree that getting a CT done is a little bit less traumatic than getting a TEE done. But the main reason we're getting the CT referral is for anatomical assessment most of the time of perivalvular leak, because the interventionalist or surgeon want to know if the patient is suitable for closure. So that's the main reason we're getting a lot of referral. We don't almost get referral in the CT lab for routine assessment of mitral valve, some rare cases. And the disadvantage of CT, we know about irradiation, that's temporal resolution. So these are what the CT look like. Not that different from the aortic valve, okay? Just different position. Obviously, mitral valve is a little bit bigger most of the time. So for aortic valve, for mechanical valve, we do the same thing. From the last week's lecture, we're measuring the opening angle, closing angle. You can do fluoroscopy. You can do CT with contrast, CT without contrast, but has to be gated. Remember, you can't just get a regular chest CT. It's not going to cut it. So for bioprosthetic valve, I put in a tricuspid valve here because this is a very traumatic case. Cases like this doesn't require too much, expertise to interpret. You see a very calcific valve, very degenerated, basically immobilized. So you have stenosis and regurgitation, high gradient, and so this is easy. So this is a case that, we have Dr. Q here and Carlos here, just present this case. So I got a referral to get a CT for TMVR assessment for valve-in-valve. So I was digging into, I said, okay, this looks like it's a nice CT picture. I said, let me look at the echo picture. So echo, this is a gradient. The heart rate was about 56. During the exam, gradient was 7. Patient has some symptom, and that's a LVOT. That's the Doppler from echo. So Carlo, what do you think? Would you call this a significant? So the Doppler is through the mitral bioprosthetic valve. Yeah. I mean, yeah. I think that definitely stenosis. How bad do you think? Yeah. Yeah, but if you look at, if we apply the Doppler finding we just talked about, you get a stroke volume LVOT of 64 and mitral valve TBI of 70. that implied to me the mitral valve area by continuous equation will be less than 1. Am I wrong? Okay, so severe, right? So the patient had MRI done before TEE. So what do you think? Should the patient have gone through a TEE or MRI? Well, I don't think anybody has. Yeah, go ahead. Correct. Very good. That's why what I was saying is this AI. That's why the stroke volume technically, because it looks like there's not much MR. So technically, the stroke volume through the mitral valve is less than 64. Let's say underestimate a little bit. And AI is what, mild to moderate. So the stroke volume through the mitral valve is probably less than 70 cc. If you have a TVI of 70, that implies the mitral valve area is less than 1. So the MRI say there's no significant prosthetic valve stenosis. Valve area 1.5, which I think is abnormal anyway. I don't know, maybe just a typo. But the valve area was 1.5, and the stroke volume through the LV was 76. It was done like a couple of weeks apart, and patient, didn't receive any. I checked, didn't receive any significant treatment. So I don't know. I agree with Carlos. The valve looks like it opens a little bit, but only one is one of the 3 leaflet. We don't know the other 2, and so I guess you can argue you can do a TEE, but I think we got referral for TMPR. All right, so this is what we saw in CT. Just like TEE, I mean CT you can get very good valve area. So what do we do when we look at a CT? We get a gated CT. We look at the leaflet motion. You can tell that leaflet opens. But I'm not at the tip of the valve, but you can look at the sagittal view. That the leaflet is definitely not normal. There's calcification. The tip of the leaflet looks mobile, but only half of the leaflet, right? And this is a little bit of thicker view. You can see the leaflet is clearly not normal, maybe not open. So the definite stenosis question is how bad it is. Which, by the way, I thought this was very intriguing. Sometimes we get a beautiful picture like this, the chordal preservation with the mitral valve. You can see the chordate. So what do we do when we evaluate mitral valve prosthetic with CT bioprosthetic valve? Number one, for the fellow, very important, look at the non-contrast images. So to give you an idea how bad the calcification is, so definitely this patient has degenerated changes, okay? And then you need to measure the size of the prosthesis, both internal and external. And the most important part is what we do very well is you look at you find throughout the diastole, the maximal opening of the mitral valve leaflet. And when you have that face, you go in and find the narrowest part, okay? Notice, different from the native valve, the narrowest opening is not always at the tip, okay? So it could be, so in this case, as you see, this is fully open. Essentially, it's like a tube rather than a funnel. So the valve area would come out about 1.2. I think that might be a little bit closer to what reality is, personally. Probably not less than 1. It definitely, I think, is less than 1.5. So that's just, and okay, so what's the cause of maybe moderate to severe stenosis? Okay, we talk about the degenerative changes, and what else do we see? Pannus, right? There's some low attenuation tissue. This is very abnormal. Okay, the Hounsfield unit is about 140, so that's most likely Pannus. And Dr. Little asked last week, and I don't have the answer for it, is where does the Pannus mostly located? If you look at it, it's not that easy to tell. I mean, I pay a lot of attention. You can say that, obviously, this area here is subvalvular, is in the ventricular side. But if you look at here, there's some tissue also in the atrial side. And I looked some literature search, most of the literature vaguely mentioned most likely is most common in the ventricular side in some literature, and some literature say atrial side. but I think it's perivalvular tissue essentially. And because the way the mitral valve is being sutured is very little, I think if you see this valve plane here, there's nothing above it in the atrial side. And most of the subvalvular tissue structure is in the ventricular side. So anyway, regardless, so this patient had probably a combination of Pannus, degenerative changes, and that caused prosthetic valve mitral stenosis. What else is very important for the fellows? So don't just look at the mitral valve. I mean, I know the CT, we don't use CT to evaluate other valve, but it's important for you to learn and look at it, to not miss it. You know, we see a little small, I call it a gap, a non-coaptation gap in CT that would technically correspond to anatomical regurgitation orifice. If you measure this, this is probably what the vena contracta diameter we see, and, you know, and you can see you can measure the diameter and the area of the non-coaptation, and you can look at pulmonic valve, which is not always easy to bring all three in the plane, and there's some mildly thickening, and the TR probably is very small as well, and so all those important things for you to at least, you know, you have the images, you can hone your skill by evaluating and looking at. So for obstructive lesion in the prosthetic mitral valve, Pannus and thrombus, I have to confess, I had a hard time finding any case of clot, because I believe most of these patients are quite sick and TE done, and they take care of it without really needing a CT. And truth is, most of the time, you probably don't need a CT unless you suspect anything subvalvular in the TE. What do I mean by that? In the ventricular side, but sometimes you can get it with a transthoracic as well. But if you want to look at, if you have question about the subvalvular or the ventricular side of prosthesis, CT could be a useful technique. So the main difference between Pannus and thrombus is still the history, okay? Chronic, slowly increasing gradient, mostly Pannus. Problem with anticoagulation, or sudden onset, most likely clot. And hospital unit, there's some small series of 30, 40 patients with pathology correlation show that Pannus usually is more than 130, 140, and less than 90, usually, or around 90, is usually implied clot. Okay, regurgitation lesion, this is, you know, not, again, you don't need to be a CT specialist. You can see there's a big gap. I don't know why it's not playing, but you can get the idea. There's a big gap here, pretty big, okay? That's why you're getting the CT for. You want to tell interventionally how big this, you put in an orthogonal view, you can measure the diameter, both diameter and the surface of the gap, so they can determine if it's too big to be closed or require surgery. Again, this is one of those traumatic cases. Patient end up, it's way too big, obviously. And this is what you want, you know, to see the full extension of the defect. So this is just a case of patient with bioprosthetic valve with a gap. Again, this is what you want to show your referral, the gap size, okay, and the location. And because especially for mechanical valve, the location and the size with respect to the hinge of the leaflet is very important, because if it affects the hinge, it could cause prosthetic valve, acute prosthetic valve dysfunction during the procedure. And this is just one interesting case of patient with perforation of the anterior aortic mitral valve curtain. In this case, a patient with multiple prosthetic mitral valve and aortic valve PVLs. And in 3D, you can see all this defect. Again, remember what I said last time. The fact that you see a defect in the CT doesn't mean there's a jet. You need to look at your CT echo, especially TE, match your defect with your jet, okay? This is I think this is one of the concepts I want to talk about. and I want to ask people's opinion because oftentimes it's been presented for the valve conference, and this patient has this history of ring put in before and has a huge gap right now, and the patient has significant MR. And the question is, should we close this gap? And the question is, whether, even if you close this gap, the MR is still coming out from here. It doesn't really solve the problem. Is that making sense? And Dr. Little tried to oftentimes make the concept for you guys to understand the reason why. Yeah, Carlos, I would like to hear.
Yeah, obviously, but it depends how that gap is closed, because this is obviously not a paravalvular leak. This is a destabilization of the annulus and
Correct.
redilation of the annulus,
Correct.
malcoaptation. So you have a jet that usually straddles that ring. Some is going behind it, some is going within
Correct.
the ring.
Because
So
the
if-
original MR is still in the valve.
Yeah, so there is restoration, if you will, of the native MR again, because now the
Right.
annulus has dilated. So
So
if the gap,
plugging this hole doesn't help.
obviously not. So,
Correct,
but
and that's a concept we try to let you guys understand why Dr. Little, because I feel like every time he mentioned it, nobody really get
But
what he
if-
was talking about.
But if that gap is resolved by putting another ring and shrinking the annulus surgically back into its, being
Absolutely.
smaller, then the native MR will go away.
Absolutely. Everybody got it clear? Yes? Good. So we don't want to hear anyone closing this with a closure device. All right. In the carditis case, I think this is Dr. Amalah's patient. Basically a young lady with COVID, had a bileaflet valve. I believe she had some bacterial infection. And again, we can't tell if this is clot or endocarditis. Mainly you need a clinical history here. And what we're looking for here, if you get endocarditis referral, you definitely need to look up for any abscess, and if you find any gap between the annulus and the prosthesis, you need to make sure you look at your TE or echo to make sure that there's a jet there. Briefly, with the transcatheter mitral valve replacement, you heard multiple times of valve in MAC, valve in ring, valve in valve. So all this refer to patients who have some prior procedure done, like for instance, a ring that we saw earlier, surgical prosthetic valve, or severe MAC. So the valve we put in here, usually the one that's been approved is a SAPIEN valve, okay? So this is a case of patient with a valve, with a ring, prior ring. And so this is one of the things that we do a lot here, planning with the special software to see the risk for neo-veto obstruction. And this is another example of planning, estimating the risk in the patient with severe MAC, valve in MAC. And this is how, virtually rendering. And this is a case, interesting case, a patient with valve in valve, it's a surgical mitral valve, and has, I believe, degenerative changes, and they put a SAPIEN valve. And echo essentially looks like this, and people freaked out. It's an LVOT obstruction. The gradient wasn't that high. And with CT, you can tell, you can understand the reason why. Because this is a 3D structure. If you cut through this LVOT plane, you can see right here, somewhere in between, outside this plane, there's plenty of room of the LVOT. Therefore, even if you see in one view complete obstruction of LVOT, doesn't mean physiologically the patient will have LVOT obstruction. And with this thickening, with MPR, you can see the whole slab, whole thickening of the structure you can see. And somewhere there's enough room for the blood to go through, and there's no physiological consequence of this apparent pseudo-LVOT obstruction. There's obstruction, but not significant. And obviously, the answer is the echo Doppler. There's no significant gradient. Okay, so this is just a rendition of it. And again, I want to show you the case, what a clips look, mitral clips look like. And we're getting some referral now, patient with assessment of patient with prior clip in, a recurrent MR, and the interventionally want to see what the remaining valve area is to determine they can go in and put another clip. So I expect as TEER population grows, some of them eventually, going to fail, and we're going to see more and more. So we got to get prepared for this. Just some example of the transcatheter mitral valve replacement, Tendyne and Intrepid. A slightly different design, but essentially have frame with anchor and with either porcine or bovine pericardium valve mounted. And just like any prosthetic valve, remember Savara, they're going to have Holt, okay? So this is not unusual. What you're going to see more dramatically is any slight changes of geometry. I don't know how you did that, but it looks pretty cool. And the one thing I think to remember, the TMBR is so much more difficult because the LVOT is ever very dynamic. It changes throughout the cardiac phases. So if you look at, when you do the planning, one phase could look very narrow, another phase could look okay. And remember, it's a summation of all this surface. So what's the physiological consequence depending how big the LV remodel and how's LV contractility after the procedure. But I think one of the most promising things with CT is we can grab these images and help interventionalists in the cath lab for planning procedure. So this is just an example of a patient with paravalvular leak, mitral valve. We put the images projected into a fluoroscopy 2D images, and we make a circle there. Now Ponraj, which is one of the scientists use word for Siemens in the catheter, he'll mark that and basically guide the intervention where the catheter needs to go. TE is still important, obviously. And this is an example. We did this fusion imaging, a patient with a prior clog already, had still significant leak, as you can see. And you can see in the CT, there's a track path go around. And then, with the fusion images, they were able to place a different tumor plug, I believe. Looks like International Space Station. Anyway. Okay, so I think this is the same slides that I showed last week, but instead of, so you have a patient who has suspected mitral valve dysfunction, transthoracic, I think is the first, and I would say 95, 98, 99% of the time you go to a TE afterward. And if you have question about quantification, you do the MRI. So for obstructive lesion, you can argue, like this case that we showed earlier, that might be a role if the patient is high risk for TE, you could skip the TE and do a CT. But for regurgitated lesion, I think TE, there's nothing like TE. 3D TE is really all you need. And only if you think about closing it with a plug or surgery or fusion imaging, you'll get a CT. So not for diagnostic purposes, but mostly for management and treatment purposes. Thank you, that's all I have. Questions? Yes, sir.
Hello. I just want to emphasize one thing that Carlos said earlier, the importance of a gradient. Particularly if you have combined let's say you have some stenosis. Testing. Thank you. So let's say you have some stenosis. It may not be severe, it may only be moderate. You may have a valve mitral valve area of 1.3. But if you have regurg, that high volume is going to give you a very high gradient. So when you have combined lesion, ignore the valve area. It's worthless. The patient doesn't feel the valve area, feels a gradient of 14, 15 with a PA pressure of 60. So gradients are very important. I want to emphasize that, particularly in combined lesions of some stenosis and regurg. That first case that you showed, Sumin, I think the CMR was worthless. I would have substituted the CMR with a stress echo because at 150, you had a gradient of 7, which is very high. That patient very easily in a bicycle would have gone to a gradient of 15 if exercise and heart rate went up and all that. And that would have given more important information to the clinician than what you got from the CMR. The CT, absolutely. Because for mechanisms, I think the CT, either CT or TE, you can argue about it. But I think in that first case, CMR was no significance because the concern was stenosis, was not regurg. And a stress echo would have done a much better job than the CMR, which basically ended up with results that were not that different from the echo. So, every case is different, but what Carlos was very right when he made that comment. Gradients are very important. It's the only thing the patient feels. Everything else are numbers that we put together, but it's not what the patient is really feeling.
Yeah, we have biological sensors for pressure, but not for area. There's no eyes in the atrium to see the valve area. It just can just sense the gradient. I just want to comment, if you don't mind, Dr. Chang, that case where you have the TAVR sapien in the mitral position, and then the idea that, if you're reading an echo on a parasternal lung and you see like like a valve in the LVOT, remember the valve has struts, right? So even if you have like this piece of metal, there's still opening. Obviously, there's some resistance to flow from the wire, but usually it's not, unless that valve has pushed the anterior mitral leaflet into the LVOT, and that's a flat surface. That is, then you might have a resistance to flow, right? So that's very important to realize that, visually you might see something.
Some part does have a stir, obviously, but usually, as Carl said, not the whole thing is covered. It's not a cover stent. Okay, depending on design, you need to know. That's why, you need to keep updated with this type of the valve design to know where the opening is, where the skirt is. But Carlo is absolutely right. Anterior mitral leaflet is mostly the responsible.
Yeah. They lacerated. Dr. Chang, I just had a quick question for you, since you like these out of normal CTs. Has there been any attempt for like dynamic imaging for like MR, for jets, like to see jets with contrast, like seeing the contrast, in the left atrium, like, because sometimes you see a gap, but you don't.
Yeah, I think theoretically and in principle, you think about it, because of how contrast flow and stay, you can track the bolus of contrast right through the aortic valve. For stenosis, for regurgitation flow is going to be difficult.
Okay.
You would have to be very sensitive or very sophisticated
attenuation
algorithm to calculate the input and output of the contrast values throughout the jet.
But I mean, like, you can't see the jet, for example, into the left atrium. You have like less contrast in the left atrium.
Very hard.
Very hard. Okay.
Yeah, because by definition, you want contrast in the left ventricle. You
to be higher.
Already have contrast in the left atrium.
Yeah.
I mean, I think somebody smarter than I would be able to figure that out.
So you could not put a. Is that working now? You cannot put a region of interest. Let's say you're looking at mitral regurg, a region of interest in the left atrium close to the MR, close to the valve, and then see a curve of how those calcium units are changing as the blood goes into the ventricle and comes out of the ventricle. Am I thinking?
Yeah, no, but at the same time, blood is exiting and entering, so it requires very sophisticated formula to adjust that. That's why the resolution. One way we can do what we call true dynamic imaging or arteriovenous imaging or time result imaging, so you can follow the contrast throughout the cardiac chamber, just like the angiogram, just like when you do the LVgram. Right?
Yeah.
The problem is, our resolution. We can only take as a heart. We can only take the highest cycling time is 1.5 seconds. So you can imagine, 1.5 seconds, you're not going to be catching every single beat.
Yeah.
Every other beat. And now, besides more radiation, it's doable, but not until we get faster cycling time.
Faster side, yeah.
So it takes a long time for the tube to power on and.
Dr. Kennard, can you speak a little bit about the protocol and the risk of the exercise testing, the risk of flash edema?
For mitral stenosis, I have never seen any flash edema. Again, you're dealing, if somebody is so sick that they're in the hospital, you're not doing anything, right? You're going, you get your information and you go to whatever you want to do. So these are mostly outpatients. So if somebody is functioning as an outpatient, they're not going to go into flash edema because you put them in a bike. I mean, they might get symptomatic, and you, at the same time, you're following your numbers, so you see if the PA pressure goes to 70, you're not going to keep going. So you have enough parameters to follow that, my goodness, in the 20 years we've been doing this, we've never had a crisis in that test. We've had them in other tests because of ischemic heart disease, but not with valvular heart disease. Yeah.
Thank you, everyone.